Hi, everyone. Welcome back. Today, we're joined by Dr. Stenehjem to give our weekly COVID-19 update in the state of Utah, to check in on what's happening since we spoke. And thank you, as always, for joining us. We appreciate it.
Thanks, man.
I want to start with cases, as always. Been a lot going on the last week. Utah has a total of 59,747 cases in the state. Our daily case count yesterday was 727 with an 18.1% positive rate. We have a 11.1% 7-day average for a positive rate. And our testing, at least with Intermountain, has been about 3,300 per day on a 7-day average. We have a total of 437 deaths and 3,381 hospitalizations. Eddie, let's break those down a little bit. How have we been doing the last week? Are we trending up? Are we trending down? What have you seen?
Yeah, I mean, we're not doing great. We are, definitively trending up. We're now reaching total daily case counts that are rivaling our peak that we had in July. Yesterday was the 7th highest day in terms of case counts that we've seen in Utah since the start of the pandemic. What's different now compared to our peak that we had in July, though, is the demographics of people getting infected. And so, when we saw this peak in July, it was a lot of people that are in the age group 25 to 44, 45 to 64. What we're seeing now is that the predominant increase in cases is in the younger age group. That 15 to 24 age group category is really showing the predominant number of cases that we're seeing in Utah. We're also seeing pretty significant regional variation. When you look at rates per county by 100,000 people, we see that Utah County has twice the rate as Salt Lake County. Salt Lake County is still going up as well. But we see an area in Utah County where the cases are concentrated, and particularly in the younger population. And so you have to ask yourself why that is. And, we can certainly talk about that as we move forward. The percent positive of 18% is, that is a significant change in addition to our case counts going up, which is just reflecting increased community transmission, most likely. Percent positive, you have to think about your denominator being tested and also the number of positives. And so it can be a reflection of either increase in positives, increase in your case count, or a decrease in testing. We haven't seen a significant decrease in testing, so it's most likely the increase in community transmission. Now, if you look at how are we doing from a healthcare network standpoint in terms of hospitalizations, we're relatively stable. We've had this really nice decline of our hospitalizations, from mid-July through August and now into September. And we're essentially flat right now. We had been declining, but now we're flat and we're at a comfortable level. The 15 to 24-year-old population doesn't routinely get admitted to the hospital for COVID-19. So they generally have asymptomatic to mild disease. I mean, certainly some of them are going to get sick, and we've seen that. We've taken care of plenty, 21-year-olds in our hospitals. But on the whole, they do usually quite well and have mild ambulatory COVID-19. What we really are worried about and what we really are watching now is what does that transmission look like from the 15 to 24-year-old to parents and to grandparents who are much more likely to get critically ill with COVID-19, end up in the hospital and potentially die. And so we're at an inflection point here, and we'll be watching very, very closely what happens to hospitalizations and case counts, especially in the older population, as we anticipate that transmission from the young adult population to the older population. And we're starting to get some sense that that is already happening with our case counts, just increasing a bit in that 25 to 44 and 45 to 64-year-old age groups.
You brought up the fact that Utah County, too, is having such a percentage of that positive case count, too, and they only make up about 12% of the actual state's population. Are you concerned that a specific county is having such an increase of cases, and is there something that you can contribute this to?
Of course, I'm concerned. I mean, we have to be flexible in our response to SARS-CoV-2. That's just the name of the game, and we have to be willing to act based on the data and implement precautions and interventions based on that data. And so, yes, we know the hotspots in Utah County. We know that it's in the 15 to 24-year-old group. And it's no coincidence that we have about, 65,000 people on 2 college campuses down there, BYU and Utah Valley, which is driving a lot of these cases. And so we really have to think hard about, okay, what are we going to do on those college campuses to reverse this trend? What are we going to do in Utah County as a whole, a county that just instituted a mask mandate in Provo, but not the whole county? What are we going to do to reverse this? Because we will see ongoing continued transmission if we don't do anything.
And someone mentioned just a second ago that they're curious as to why there's such a big spike if we're all wearing masks. If we are having these necessary precautions that we're taking against COVID, how are we still seeing community spread?
Yeah, we're
Is
not
it because we aren't wearing them?
Yeah, we're all not wearing masks. I mean, that's pretty simple. I was down in Utah County last weekend, and I would say less than 50% of the people I encountered were wearing masks. So it's as simple as that. I mean, it's that we're not all wearing masks. And, I think the younger population clearly has social forces that are stacked against them. I mean, they are in a really hard situation. And I mean, I can remember when I was a freshman in college or even a senior in high school, how important my social network was and how important it was for me to be, being engaged and going out and doing all those things. So it's really, really hard for them. And we can't deny that fact. We're now asking them to wear masks. And there's no underplaying it. Like, this is a really challenging population. And but the fact of the matter is we're going to need to do something to stop this transmission. I doubt that we can isolate this to the college campuses. I mean, let's just theoretically say we can keep our professors, our custodial staff, our older people on those campuses safe. Let's just theoretically say we can do that. Then you could say, well, maybe we'll just stay on the campus, but that's not the way our campuses work. Many people commuters are going back home after school, and this is going to spread more and more in the community, and we're going to have to be instituting something to change this trend.
And can you give a little bit more context to that 18% positive rate as well? You mentioned that it's very high, but what exactly does that mean? Will you break it down a little bit more for us? We've also heard that rates above 10% can indicate that the situation is potentially getting a little bit out of control. So you see the statistic of 18.1% for yesterday. What does this mean to you as an infectious disease physician?
Yeah, so the percent positive can be a very good test or marker of ongoing community transmission. So what that percent positive, it's simply the number of tests that were positive divided by the total number of tests that were performed that day. That gives you your percent positive. And so really what this test looks at is 2 things, is the number of positives over the total number of tests. So the way you can increase your percent positive is by increasing your number of positives while holding your denominator or your total number of tests stable, or you can shrink the number of tests performed, and that's going to also increase your percent positive, even if the number of tests that are positive stay the same. The challenge with it is that the epidemic, the pandemic is dynamic. The way people are reacting to the pandemic is dynamic. And so, early in the pandemic, there was probably lots of people going out, getting tested. We were unfamiliar with the disease, the symptoms of the disease, and there was such heightened community concern that we were probably testing a lot of people that didn't necessarily need to be tested. That way you kind of engage and interpret the disease, it changes through time. And so we may be changing the denominator of the people that are actually going to get tested. So that's can make it a little bit tricky. That said, when you see these significant jumps day to day, and we aren't changing our interpretation of this pandemic in that short of a period. So if you start seeing this 10%, 11%, 18%, that tells you something's changing with the community transmission, especially as the number of tests you've performed have stayed stable. And so in this instance, we can compare the percent positive to the previous days, because we're really not likely changing the population getting tested in that shorter period. it's harder to compare our percent positive now to back in, let's say, April and May, where maybe our interpretation of the pandemic was different. But seeing this acute rise in percent positive, that's real. And that's just showing us that the community transmission is changing. It's also saying we need to be testing more people and getting a better handle. We want to get that percent positive lower to say that, we're testing more people, we're identifying those that are positive and potentially doing contact tracing, or at least making sure people quarantine if they've been exposed.
And you might have mentioned this previously, but let's talk about it again. What do you think we can really attribute to this rise in cases? Is it the fact that Labor Day was a few weeks ago? Is it the fact that school has been starting up? I do believe most schools are now in session, including college campuses. So were we expecting to see some sort of rise in cases? And if we were, is this rise the rise we were expecting to happen?
Yeah, so a lot of things have happened in the past month, right? So Labor Day happened, end of the summer, people were, gathering and socializing together. School started going back in session right around mid-August, a number of different models, hybrid, remote, in person. We had college campuses come back. We've certainly seen all those images about, different parties that have been on college campuses. And all of these things happened within, a 2 to 3 week period. So were we anticipating a rise? Yeah, we sure were anticipating a rise. And this is the rise we were certainly expecting. I do think we need to say that it is very notable that when you look at the kids 1 to 14 years old, we have not seen a significant spike in those cases. I mean, we've seen a small spike, but we haven't seen a huge rise like we've seen in the 15 to 24-year-olds. And when you look at the average age of the students getting infected in our schools, that average age is 16. Okay, so what this is telling us is that those elementary schools and middle schools, yes, there's been outbreaks. Yes, there's been isolated cases. You can certainly point to those. But we're seeing that if they're following the protocols that they've set up in the elementary and junior high schools, that they're remaining relatively safe. And we're very cautiously optimistic about those school-age children, elementary and middle school. When you look to the 15 and up, 15 and 24, that's where you see the spike, and that's being driven by high schools and colleges most likely. And we've seen Riverton High School struggling with whether or not it's going to close. We've seen other school districts struggling with having more than 15 cases and trying to understand whether or not they're going to close, go to a full remote or not. And talking with some of these people, it seems that it's not necessarily the transmission that's occurring in the classrooms, but those that are occurring in extracurricular activities and social settings. And so, to answer your questions, yes, we expected this. And two, it's driven by most likely high school extracurricular activity, college, and social events in that 15 to 24-year-old age group.
You just brought up my next question was about those two high schools. They actually made their decisions late last night, I do believe, to stay in school. The specific question I have for you is, if these schools are ignoring the state health department's recommendations, how are we supposed to move past things? What can a parent do to help make sure their child isn't getting sick? And what recommendations do you have for us as a state if we're not going to follow the guidelines that we originally put in place?
Yeah, I'm obviously not on the school board, and I don't have children that are in high school. And, so I can just comment from an infectious disease perspective is that, if we don't do something, we can't expect a different result. I mean, we can't just hope that this gets better. So, I would say is, listen, if we're not going to follow those, very reasonable guidelines put forth by the state health department, well, what are you going to do? What are you going to do to change the current pattern? You got to do something, because doing nothing, you're just going to get the same result. And so, as a public health person, it's more of like, okay, you've made that decision, and I could certainly understand why you've made that decision, because of the benefits of children being in school. But at the same time, you're going to have to change something. We're certainly seeing increased cases in high school, and I would reflect to them to say, you've made the decision, now tell us what you're going to change.
So Another question for you along those lines too is, you mentioned that the spread isn't actually happening within the classroom walls itself. So does that mean that children are potentially going to school when they're sick? And how can, as a parent or even as a 16-year-old, stop myself from going to school? Should I be staying home if I feel any sort of symptom at all, or should I be going to school if I only have like a cough or a slight sniffle? What's your recommendation on that? Because if it's not being spread in the actual school, obviously some are coming to school who are presumed positive or had some sort of exposure.
Yeah, so this one is, SARS-CoV-2 is a respiratory viral illness. And so in adolescents, in children, we know they can cause very mild disease that is indistinguishable from any other respiratory viral illness caused by any host of different viruses, whether it be seasonal coronavirus or adenovirus or rhinovirus. It is indistinguishable at this point. We have no way to determine, just based on symptoms alone, whether a child or adolescent or young adult has SARS-CoV-2 versus another virus. So if somebody has any symptoms, whether it be a new sniffle, a new cough, those people cannot go to school and they need to get tested. And so we're developing our algorithms, and honestly, it comes down to the fact, if you have an upper respiratory infection, you need to get tested, period. You cannot go to school, you cannot go to work. You really have to, isolate yourself and ensure that you have, decreasing the number of contacts. We cannot distinguish this. And this is going to be really hard as we move into the fall and into the winter, where we see a spike in viral respiratory illnesses. And we're going to have to be, very, very vigilant and have the discipline to say, listen, I may feel okay. I think I could probably go to work or school and be functional. But you could have COVID-19. You could have mild COVID-19, and you need to stay home until you're better, and you need to get tested. Because if you're positive, you need to stay and you need to self-isolate for 10 full days. And so it's really important for us to do that. Keep in mind, and there's been now in the literature demonstration of this, even here in Utah, of asymptomatic spread from children. And so we know that in extracurricular activities, some of those precautions that we take in the classroom aren't being done in those extracurricular activities. And so that allows asymptomatic kids to go ahead and transmit SARS-CoV-2 if they're asymptomatic. So unbeknownst to them, they have no symptoms. They're doing everything right, except they're shedding SARS-CoV-2 and infecting other people. And just recently in the MMWR, that's the CDC journal, they highlighted 3 outbreaks in Utah in child care centers, and showed that yes, indeed, children can transmit this virus. They can do it when they're asymptomatic, and they can transmit it to adults. And in that case, one of those adults were hospitalized. And so it's very clear that asymptomatic transmission occurs. That's why we put in these precautions in the classrooms: 6 feet, mask, hand hygiene. But as you move to extracurricular activities, asymptomatic people can spread. And that's just the fact of it. And that's why we're seeing a lot of this spread.
And in that case you just mentioned too, for the CDC reported on, they were in child care centers too, of everyone that was under the age of 10. And previously we were under this assumption, or we didn't have enough data to really support yet, that children could spread it. But it sounds like we are learning more about this, and we are seeing those effects. And there's a really great chart on the CDC's website that talks about this specific case, and it kind of shows the flow of the person moving from being infected to getting their parents infected to someone actually being hospitalized. So it shows that even though your child might not end up in the hospital, someone they come in contact could end up in the hospital. And I think that's really important to talk about. I want to talk about that 15 to 24-year-old age range a little bit more too. You said a lot of them are ending up in the hospital, but because it's such a huge spike with that age range, when, if we do, could we expect to see an increase in hospitalizations to people that are older that they interact with?
Yeah, so I think it is important to know that, those people, 15 to 24-year-olds, certainly can get severely ill, and they can get sick, especially those with comorbidities. And so we see that obesity, diabetes, immunosuppressing conditions can lead to severe disease. And so absolutely, we'll likely see, a small bump in hospitalizations due to that age group. you really then have to think about the transmission of the virus, right? And so you've got the 15 to 24-year-olds spiking right now. They're now likely transmitting the virus to older folks, whether it be parents or community members or grandparents. Then you think about the incubation period for them. And so that's, again, 5 to 7 days on average, but out to 14. Then those people have to get sick and get sick enough to warrant hospitalization, which is typically 7 days after coming down with symptoms. And so, I would anticipate that if we're going to see an increase in hospitalizations, that it's probably going to come in, 2 to 3 weeks from now, which allows time for transmission, incubation period, symptom onset, get severe enough ill, and then you're coming into the hospital. So I would say probably 2 to 3 weeks we'll, watch this. And what we will probably start to see is an uptick in cases in the older age groups, kind of, being offset by 10 days or so from those of the 15 to 24-year-olds. And so we might start seeing the second wave of older people getting the infection, which is then going to lead to hospitalizations. And so, I would predict 2 to 3 weeks before we start seeing an increase in hospitalizations, especially in that older age groups.
And in about 2 to 3 weeks, we're getting into colder weather, which equates to the flu. I want to talk a little bit quickly about the flu. Looking ahead, what symptoms should people know about the flu versus COVID-19? Is there really a way to distinguish between the two of them if you're not getting tested? And how does someone go about deciding whether they should stay home if they think they just have the flu versus COVID-19?
Yeah, so, a couple things has happened that's really kind of limited our knowledge in the co-infection with influenza and COVID-19. One is that when COVID-19 really hit the US, and particularly in Utah, which was really in early April, that was at the same time that we saw this precipitous decline in influenza, which is normal for that type of year. And so as we started to get more cases in April and May, there wasn't influenza circulating. Okay, so we don't know a lot about that interplay between SARS-CoV-2 and influenza. There is some data out of Stanford early in the pandemic that clearly showed that you can have viral co-infection, meaning that if you're diagnosed with flu, that doesn't mean you shouldn't test for COVID-19. You can definitely have both. Then we hope to learn about the interplay between flu and SARS-CoV-2 in the Southern Hemisphere during our summer, their winter. And what happened there is fascinating, is essentially influenza has disappeared in the Southern Hemisphere in a lot of countries. So Australia, Chile, there's a number of countries that have reported on this, and their influenza cases have declined significantly. And that's likely due to decreased travel from Northern Hemisphere to Southern Hemisphere, and due to all the precautions that they put in place for COVID-19, which prevents transmission of influenza just like it does SARS-CoV-2. And so now we haven't learned anything, from the Southern Hemisphere at all. And so now we're going into flu season. And we know that influenza-like illness is the same thing as COVID-like illness. And influenza-like illness is fever and respiratory symptoms. Well, that's what COVID-19 does. And so there may be some subtleties that, healthcare professionals that see a lot of this could potentially tease apart. But the fact of the matter is if you have fever and a respiratory symptom, thinking influenza, you've got to get tested for SARS-CoV-2. It's just that easy. We're not going to be able to distinguish these two, and we're going to have to test for both. And so there are some new diagnostic tests that are coming out that we will be deploying that is able to test for both influenza A and B and SARS-CoV-2. And so we'll really need to be utilizing those, especially early on in the respiratory season, to see if and when influenza starts to tick up, and then be able to learn a little bit more about that interplay. But for the public's perspective, these are indistinguishable infections. They're both respiratory viral illnesses. They both can cause fever with cough, sore throat, and myalgias. And so you're just going to have to get tested for both.
And what about a vaccine for the flu? It's something we have in Utah. I know at Intermountain, we're starting those vaccines pretty soon. We'll be releasing a little bit more information about where you can get them. But why is it so important, especially this year, to get a flu shot, especially if you've maybe just never gotten one in the past because you've never really wanted or needed one?
Yeah, it's absolutely critical to get a flu shot this year. We anticipate, I mean, we're seeing this spike now. We anticipate seeing a rise in hospitalizations coming in 3, 4, 5 weeks because of this spike. And we cannot have our hospitals full of people with severe influenza, which we see each year. We have to be able to steward those resources. And with influenza, we have a very simple intervention that prevents severe disease. Is the flu vaccine perfect? No, not by any means. That said, it does prevent severe disease. It prevents people from being hospitalized and dying from influenza. And so this very simple act of getting a flu shot will save our hospitals those beds that we're going to likely potentially need for people with SARS-CoV-2 in which we don't have a vaccine. And so this year is incredibly important to get your flu shot. Flu shots are safe. They do not cause the flu. And they're going to be available. They're already starting to be available now and within Intermountain. And it's really important to get that flu shot at least by the end of October. And so I'd say get out, get your flu shot now, and really, try to protect our hospitals from being influenced by severe flu so we can have the capabilities and capacity to care for our COVID-19 patients.
You brought up that you don't get sick from the flu shot. And I think it's important to note that I was reading about this last night. It typically takes about 2 weeks or so for your body to actually adjust to the vaccine that you're getting. And in that time period, you could get the flu.
Mm-hmm.
I know that when I've gotten the flu shot in the past, I'm like, oh, I feel sick. And it's probably because I got the flu before the vaccine actually took effect into my body. So I think that's important for people to know, is that it's just like with COVID, you could test negative one day, go out, be exposed, and then be positive for the virus. It's important to continue to take precautions regardless of the fact that you have a vaccine or that you tested negative for it one day.
Yeah, and also keep in mind the flu shot doesn't prevent upper respiratory infections. It doesn't prevent rhinovirus. It doesn't prevent any of the cadre of seasonal upper respiratory viruses. But you get the flu shot during that season. And so, there's plenty of people that say, oh, I got the flu shot and then I got sick, or I got the flu shot, it never works. Well, the vast majority of times because people have seasonal, respiratory infections and don't actually have the influenza virus. Influenza virus is a severe infection, severe high fevers, myalgias, you feel terrible. And most people don't have that. They're typically, getting a respiratory viral infection at the same time they're getting the flu shot, which happens just because that's the time we give the flu shot. So yeah, people don't get sick from the flu shot. They get sick from other respiratory viruses that aren't covered by the flu vaccine.
I want to talk about two things related to masks really quick. The CDC has been telling people that masks are not stopping unhealthy particles related to smoke from the fires. Someone wants to know how a mask is going to stop particles from COVID if those are generally smaller. And the difference between, I guess for me, this question is a surgical mask protecting you from COVID versus a hazmat mask or something of the sort protecting you from smoke fire. Why does one work but the other doesn't?
Yeah, I mean, keep in mind, SARS-CoV-2 travels on large droplet particles. And so large, wet particles that are coming out from your mouth. SARS-CoV-2 is a tiny virus. Yeah, absolutely. The virus itself can pass through masks, no problem. But that's not the way that the virus travels in air. And so in air, it travels on respiratory particles. It doesn't come out by itself. It comes out on respiratory particles in which the mask stops. And that's the reason we wear masks, to prevent transmission in the community and also likely to protect yourself from getting infected from somebody else. It's very different than the air we breathe, which is full of smoke, right? Those are tiny particles. And of course, it's going to go through a cloth mask. We breathe just fine with a mask. Our oxygen levels don't change. And so you're going to be getting smoke with those types of masks. The masks that we wear for COVID-19 are designed to prevent the spread of large respiratory droplets, which is what SARS-CoV-2 travels on. It's simple as that.
Another question for you. The volume of testing seemed to have dropped for a little while in the state of Utah. Has it picked back up at all? And is this a concern one way or the other for you?
Yeah, I mean, obviously, I'm a proponent of testing, and it's very important to know your status, of COVID-19, especially if you've been exposed. And so when we look at the number of tests, you're right, we definitely peaked in the number of tests that we did really kind of early to mid-July. And then it's dropped off a bit since then. And I think it's probably, if you look at those that are symptomatic, it's probably even less than what we're reporting out, because we're also reporting a lot of testing of asymptomatic people prior to surgeries and procedures and those things. And so, yeah, it is something that concerns us, because it's really important for people to get tested if they have symptoms, to know whether or not they need to self-isolate. And so, if you're positive, you got to self-isolate for 10 days at a minimum. And so it is something we really, really strongly encourage people to get out and get tested if you have symptoms. All of our curbside testing are still open right now. And so the wait times are lower. Our turnaround times for testing is right around 24 hours, maybe to 48. But we have, good turnaround. Intermountain is going to be moving to a saliva-based test. And so starting around the 24th of September, our curbside testing will be saliva-based. And so we're not going to have to, put that swab in the back of your nose, which is quite frankly uncomfortable. And so we're really trying to decrease the barriers to testing. And one of them is going to saliva. And so it's really, we got to encourage people, if you have symptoms, even mild symptoms, get out, get tested, know your status. And so then we can prevent this transmission in our communities.
Another person wanted to know why we can't just let COVID-19 run its course. If it's going to happen, if people are going to spread it, why can't we just stop with the precautions and let people get COVID-19? What happens to our hospitals if that's the case?
Yeah, so if we, let our guard down and let this spread like, I hate to use the term wildfire, against what's going on in Oregon, California, but I think it's apropos. If we just let this spread, yeah, a lot of people will get it and a lot of people would do just fine. That said, there's going to be a lot of really sick people, and will very quickly outstrip the capacity in our healthcare system to care for those people with COVID-19, and not allow us to care for people without COVID-19 that need our hospital services. The car accidents, the heart attacks, the strokes, the bacterial pneumonias that we care for day in and day out, those people won't get the services that they need. Okay, and maybe you say, oh, that's all right, like I don't need the hospital, but you might. You might if you're in a car accident, you might if you have a trauma. And so it's something that we would far exceed our capacity in healthcare. We wouldn't have the ventilators, we wouldn't have the personnel to take care of people. And you could say, oh, well, we can just open up beds in, downtown in a stadium and we'll take care of people that way. But beds don't take care of people. People take care of people. And we don't have the number of ICU physicians. We don't have the number of hospital-based physicians. We don't have a number of infectious disease physicians or pharmacists or nurses to care for people. And so, it's as simple as just saying, listen, we're not going to have the capacity to care for people that get severely ill if we let our guard down and let this, widely go through our communities.
I think that's really important to note, that a lot of people do ask about ICU bed capacity and not the actual people that are caring for you. Mm-hmm. So it's very important to remember that, like you just said, a bed doesn't care for someone, the actual people that are specialized care for them. So very important to remember. One more question for you is about vaccines. Pfizer CEO recently came out and said that the status of their vaccine should be known to the company by the end of October. And if it's safe, effective, and gets approved by the FDA, they should have something ready to be distributed to Americans by the end of 2020. We talked about vaccines a lot and the need to have a 6-month bank of data at least. What are your thoughts on a potential vaccine coming out so soon, and the fact that they think they can find out if it's effective in almost a month?
Yeah, it's troubling to me that they would say with 3 months of data that they will be able to determine the safety of this vaccine. Pfizer started its phase 3 trial in July. I'm not sure the exact date, but towards the end of the July. And so essentially what the CEO was saying is that we're going to be able to have data to show the effectiveness of this vaccine by October. That I don't doubt. That you may be able to show effectiveness. So you may be able to show that getting the vaccine reduced the incidence of disease in the people that received the vaccine. And if they vaccinated populations in areas with significant community transmission, yeah, I bet you could determine that in 3 months in an appropriately deployed vaccine study. What I worry about is that you don't have data in terms of safety. You don't have data in terms of something called antibody dependent enhancement, where you get the vaccine and now the vaccinated person, when they get infected, actually have more severe disease. That's one of our concerns about the safety of these vaccines. And I worry that 3 months is just not a lot of time to really understand the safety of the vaccine. And that's essentially what they're hedging. And I would much rather have more time and then deploy a safe and effective vaccine than rush and try to get a vaccine out too early that potentially could have detrimental or safety effects. And if companies push this too quickly and we get a vaccine in the community and it either doesn't work or has safety signals, I worry that that's going to deter the rest of the community from not getting a vaccine when a safe and effective vaccine does come out. And so I think we really have to be careful with this. It'll be interesting to see what Pfizer does, what Moderna does, what Oxford vaccine does in terms of that 3-month time period, and if they're going to release data and what their safety profiles look like. I think more importantly, it's going to be up to the FDA, and the FDA is going to have to make a determination on whether or not they're going to grant an emergency use authorization or an EUA, like they've done with plasma and hydroxychloroquine and some of these other things, and whether or not they're going to grant that with 3 months of data. We're just going to have to wait and see, and then we're going to have to make a determination of, whether or not that's a vaccine we're going to deploy if we get any. Keep in mind, Pfizer is one company that will have a vaccine that potentially could go out to the US and the rest of the world, and what would our allocation be? And who would we give that to? And so a lot of hard discussions and decisions will be coming, especially if they're releasing a vaccine early.
Eddie, last question for you. What advice do you have for people as we move forward into this flu season and as things continue to kind of trend upwards?
Yeah, don't let your guard down. We've been in this a long time, and we're going to continue to kind of go through this for months to come. And so the messaging hasn't changed. It's decreasing your close contact. It's wearing a mask. It's remaining 6 feet apart. Avoid large crowds. Good hand hygiene. And all of that is harder to do in the winter. And so in the summer, we're lucky to be here in beautiful Utah, where we can get out in the mountains and get outside and enjoy people's companies safely outside 6 feet apart. In the winter, we're moving indoors, and we're moving into close quarters. We're shutting windows. The ventilation in our classrooms and in our homes is going down. And so it's going to be a bigger risk, especially as cases are going up. And so we really have to think about, what are we going to do individually to maintain our social interactions as we move into the winter, but do it in a safe and effective manner? How is that going to look for everybody? Are we going to engage outside and use heat lamps and heaters, and so we can get those social interactions that we need? We really going to have to, I'd say, think about it now, but know that the core principles are not changing. It's, remain 6 feet, wear a mask, decrease your close contacts, wash your hands, increase ventilation. And we're just going to have to make a plan for that.
Thank you, Eddie. I think that's really great advice. And just to remember that we're not over this. This hasn't disappeared. So it's important to keep up your guard. And if you guys have any questions about COVID-19 and would like to speak with someone, our COVID-19 hotline is still available. That phone number is 844-442-5224. We also have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Eddie, as always, thank you for joining us, and we'll speak with you next week.
Thanks, Amanda. Thanks, everybody, for being with us.
Thanks, guys.